Hello and welcome to our first Rural Doctors broadcast for 2009. I'm Jerry Gannon. Thanks for your company. Before we begin, I need to let you know that due to circumstances way beyond our control, we're no longer able to receive live phone calls during the program. While this is a bit unfortunate, it does mean that we're less bound to the studio here in Perth, and we'll be looking to get out and about a bit more, hopefully to more rural and remote areas of the state, to bring you a more diverse and rurally focused program. However, it does make it even more important that you complete and send in your broadcast evaluation forms, including any questions for the next broadcast, so that we can make sure your questions are addressed. Our program tonight looks at the heart. Now, you should have received a collection of ECGs with the evaluation form for this broadcast. Keep them close by because a little later in the program, cardiologist Dr. David Playford from Heart West will talk through these ECGs and discuss what each of them is telling us. We'll also hear from Dr. Jenny Deeg from Heart West and Dr. Laurie Dembo from Envision Medical Imaging about some of the cardio imaging techniques now available. In particular, we'll discuss 3D echo and calcium CT imaging, and if you're not already familiar with these techniques, then I think you'll be surprised by the quality and clarity of the images that can now be achieved. Those stories later on, but right now let me introduce our studio guests. Dr. Olga Ward is back on board with us. Welcome back after the long break, Olga.
Thanks, Jerry.
And to answer her question and yours is a cardiologist that well knows the trials of rural medicine. Dr. Johan Janssen, welcome to the program, Johan.
Thank you, Jerry. Nice being here.
And Olga, the heart. Let's go.
The heart. Johan, rural GPs are often confronted with patients who have quite equivocal chest pain, particularly in the emergency department in the middle of the night. So how do you sort out the patients that it's quite safe to keep and investigate in a rural area and the ones that should really go off?
Well, you started with the most difficult question of all straight away.
Of course.
The essence are still the same as always, which is the history of the patient and then the combination of the history with the risk factors of the patient. So does the patient have a family history of coronary heart disease? Does the patient have hypertension, dyslipidemia? And then if you think that the patient does have risk factors, you look into the type of complaints. Are the type of complaints typical? Do they have Levine positive, which is the squeezing chest pain that they feel, or chest tightness that they feel? Is the distribution of the pain typical, yes or no? And then after that, you got your biomarkers. So what we have now also available in the rural area is the troponin and the NT-proBNP. Those are very sensitive markers to check whether people would have or would not have a cardiac origin of their pain. So the BNP and troponin bedside measures are newer, and I know in Cal they have them in the emergency department, and we can also take them out with BGAT to the rural Aboriginal communities.
So that's for your patients who are presenting with acute chest pain that's definitely ischemic in origin. There are often patients who have other types of chest pain that are cardiac in origin, but possibly not first ischemic. And I'm thinking about the patients that might present with acute atrial fibrillation. What's the current best practice guideline for that?
I think that we have to come to realize that the initial atrial fibrillation guidelines said that it would be all right to just accept atrial fibrillation and control the heart rate between 60 and 100 when the patient is in rest or exercising. But now we come to realize that really we should have efforts trying to get rid of the atrial fibrillation altogether. Now that depends on several factors, the age of the patients, what the cofactors, comorbidities are. But nowadays we try to be very aggressive and maybe offer the patient ablation of the atrial fibrillation. Ablation is that we are able to go with the catheter into the heart, find the particular areas where the atrial fibrillation is located and burn away those pathways so that the atrial fibrillation doesn't occur anymore or doesn't occur over the whole of the heart. Now, we can do that nowadays very elegantly with computers and a system called the CARTO system. And in WA, it's available at Charlie's for Medicare rebate patients and at St. John of God in Subiaco for privately patients.
Okay, well now that sounds pretty complicated. My memory of country emergency departments is reverting the patients to sinus rhythm with things like amiodarone infusions. Are they completely out?
No. I just wanted to highlight that the atrial fibrillation treatment has really been advanced over the last year here in WA. Now, if you have a patient with atrial fibrillation, your first idea is, can I get the patient back into a normal rhythm?
Yeah.
What we do for that is, if you are pretty sure that the atrial fibrillation didn't occur longer than 24 to 48 hours, you can decide to zap the patient, cardiovert the patient.
Yeah.
You cannot cardiovert the patient when he is awake, so you have to have the help of a GP anesthetist to put the patient to sleep with a little bit of propofol and midazolam. If you don't want to do that because of various reasons, then you try to convert the patient chemically. If you want to do it orally, you give the patient 80 milligrams of oral sotalol and you wait for 2 hours. If the patient hasn't converted, then you can give the patient IV amiodarone. If you want to not give the patient a beta blocking agent because you might think that the patient has COPD or something, you go straight for the IV amiodarone. And there are protocols in each emergency department how much to give. You give a bolus, then you give continuation of medication. You do have to remember, though, that 40% of patients will revert back into sinus rhythm within that set period with doing nothing.
Yeah.
So you might as well, if the patient is stable, just sit back and wait.
Okay, now I have in the back of my mind that patients that are going to be cardioverted need to also be anticoagulated. Is that correct for an acute situation?
In an acute situation, not necessarily, but now we are living in a nanny state, so everybody is giving the patient that is going for cardioversion Clexane if you do it acutely.
Yeah.
For the past 20 years I haven't done it, but it's like I said, people think that it will do something. The risk of having a thrombotic event happening when you cardiovert a patient without anticoagulation, if the atrial fibrillation had occurred only very shortly, is extremely low. That's why you can do it. Now, if you decide that the patient might have the atrial fibrillation for longer than the 24 hours, then it is safer to put a patient on warfarin. Make sure the INR is between 2 and 3.5 for at least 6 weeks, then cardiovert the patient.
So do it as a much more elective.
Then you have to do it as an elective procedure. Now, the 6 weeks that I mentioned is arbitrary. If you ask 10 cardiologists, you might have 12 different answers. But I think that since the consequence of a stroke is that big for the patient, it is better to be safe than sorry. So, the patient is hemodynamically stable, so we don't mind if it is 4 weeks or 6 weeks. I'd rather go for the 6 weeks.
And
Important though is that once you cardiovert the patient, after you had them on warfarin, to continue the warfarin for a number of weeks afterwards.
And what are your chances of the patient staying zapped or staying cardioverted from the amiodarone after you've reverted them to sinus rhythm?
Low. I always tell the patients that atrial fibrillation will come back.
Yeah.
The only thing is we don't know when, and the treatment is concentrating on trying to make the delay as long as possible, but it does come back.
So the patients that we might diagnose instead of in the emergency department, so just by taking their blood pressure and feeling their pulse and thinking, oh, that's not right, so the asymptomatic but stable patient, are you using the same kinds of treatments or do you go straight into the ablation pathways? What do you do with them?
We are very aggressive. We go to treatment, so medical treatment, depending on whether the ultrasound shows whether the heart is structurally normal or not normal. and then we go pretty quickly to ablation. You have to rethink the issue when you find that the patient does not have a structurally normal heart. If the patient has a cardiomyopathy, if the patient has coronary artery disease, if the patient has valvular disease, then the treatment will be different. And the patient might be better treated with bypass surgery, for instance, or valve repair than having an ablation for the rhythm, because the rhythm is caused by the underlying disease. So if you have a structurally normal heart, then ablation is nowadays my first choice.
Sounds like... Sorry.
You're 30 years of age or 40 years of age, you had one drinking binge, you get atrial fibrillation.
Yeah.
Do you want to pop pills for the rest of your life, or do you want to have a more definite solution? So that is what we're trying to communicate with the doctor, that we have those options now.
It sounds like cardiologists are doing a considerable amount more in the way of procedural work these days. Could you talk about stents and bypass grafting and angioplasty, and when you decide to do which of these and why?
The origin of trying to revascularize the patient came very early on in the 70s, when we realized that the patient that had obstructive coronary disease didn't live as long and didn't have the quality of life as you would expect from somebody who had normal coronary arteries. So we started by trying to offer them revascularization therapies. And originally that was bypass surgery, which was cumbersome. You had to cut the chest. We had to develop heart-lung machines and things like that. And then Grunze came with a balloon dilatation. You put in a little wire, and over the wire a little balloon. The balloon cracks over the lesion, and it looks very nice. Nowadays, we realize that any of the modalities that we have, atherectomy, laser therapy, balloon angioplasty, stenting, operation, and aggressive medical treatment, have long-term the same outcome. So actually, we learned that we have many modalities, and what the challenge is, which modality is suitable for which particular patient. Now, the newest things we have is that we put in a little spring, a little stent, made of a inert material coated with a biodegradable material, or with a drug to make sure that the blood vessel doesn't react to the fact that we put in a foreign material. And those are called the stents. Now, after being very enthused initially, now other colleagues are getting very upset. Why? Well, if you want to make sure that the stent stays open, you have to give the patient aspirin and clopidogrel. You have to give them antiplatelet treatment.
Yeah.
It doesn't thin the blood, but it really makes them bleed. So if a patient having a stent is being put on dual antiplatelet treatment, a surgeon cannot just go ahead and take out the appendix, cannot have an elective hip. Mm-hmm. And the patients don't like that. They say, oh, wait a second, now suddenly my heart is fixed, but I still can't walk because they cannot do my hip for 12 months because I have to be on these drugs.
And it's 12 months.
It is at least 12 months. Now, there are two things to that issue. One is there are new stents in development that probably will reduce the need for that prolonged time of anticoagulation or antiplatelet treatment. That's number one. So there is good news on the horizon. Not here yet, but it's going to come this year or the end of next year. Second is that there is a real progress in development of real biodegradable stents. So you put in a stent, after 2 months, 3 months, the stent is being absorbed. There's no more foreign body in the blood mm-hmm. vessel, and the problem has been solved. So those are big things to look forward to in the short term.
Yeah. Now, we hear occasionally of things called drug-eluting stents. Does that mean that you've got a stent that's leaking clopidogrel into the wall of the artery, or what does it mean?
No, they have drugs called like sirolimus. So they are drugs designed to try and reduce the inflammation reaction of the vessel wall. And they're the same drugs that we have experience with in people that receive heart transplants or kidney transplant to try to dampen down the immune system. And there are some problems with those drugs because we cannot really control the delivery of those drugs and the rate of delivery of those drugs. And that made that there have been some incidents that people did not get a complete recovering of the stent struts. So you have to imagine.
So then you've got an exposed foreign body on the interior of the artery.
Correct.
So not as good as they sounded.
Definitely not.
And Johan, just before we go to the break, could you tell us a little bit about some of the pathway ablation things that you do and how they work?
Yes, that's very nice. You got another 20 minutes? Now, what we can show is that the current medical imaging techniques, which we also talk about differently in the program, can show us beautifully where the abnormalities are in the heart.
Yeah.
And these devices can help us to very accurately pinpoint where the atrial fibrillation, where the extra pathways are located, which means that the success rate from initially 20%, 30%, in very good hands, 60%, now goes up to 80, 90%. So these current improvement in imaging techniques in the cath lab have enabled us to just take the whole treatment of all kinds of arrhythmias, atrial fibrillation, WPW, AV nodal tachycardia, atrial tachycardia, ventricular tachycardia, idiopathic ventricular tachycardia, to a whole new treatment level. What was available in Paris, in Maastricht, in New York, now is available in Perth, and I think that's a big plus.
Yeah, and we might leave it there and go to a different segment and come back and pick it up.
Thanks, Olga. Well, the ECG is the number one tool in the diagnosis of heart problems, but like any diagnostic tool, they're only as useful as our confidence in interpreting the information they offer. If you have that set of ECGs that we sent you with you, pull them out and have a look at them while Dr. David Playford from Heart West talks us through what each of these ECGs is telling us and what action, if any, should be taken in response to them. Now, hopefully you'll have recognized ECG number 1 as a normal ECG, so we started by asking David about ECG number 2.
David, could you have a look at ECG number 2 and tell us what's going on there?
This is a patient who presented with retrosternal chest pain of 2 hours duration that sounded ischemic, and on the ECG you can see that that in the first of all the rhythm is sinus rhythm. The rate is about 60 beats per minute, and if you look in the inferior leads, which is leads 2, 3 and AVF, you can see that there is ST segment elevation from the beginning of the ST segment to the beginning of the T wave. There is elevation of that entire segment, which is consistent with an inferior myocardial infarction in evolution, taken in context of the history. So it's very important to join the ECG changes with the history to make sure that it's happening as we speak.
Are there any ischemic changes that are acute that are much more subtle than that fairly obvious inferior infarct?
Sure. There are some infarcts that present in a slightly more atypical sort of way. The first thing always is on the history. If it sounds ischemic, then always be concerned that it is an infarct or at least an ischemic pattern that's happening. This is somebody with an evolving true posterior myocardial infarction. Nowadays we try not to use the term true posterior. In fact, it's really a basal inferior. In fact, it's one of the forms of inferior myocardial infarction. But you can see here on leads V1, V2, V3, and across the other 3 anterior leads V4, V5, V6, you've got ST segment depression, but an upright T wave, particularly obvious in leads V2 and V3. And you also can see that the R wave is bigger than you'd expect it to be in V1 and V2, particularly obvious in V2. Normally the R wave is smaller and gets bigger as we go across the rest of the anterior leads. In leads 2, 3 and AVF, which are the inferior leads, there is ST depression, but there's no elevation there. So these are the changes that we see in somebody with an infarct that is at the back of the heart, and so the ST segment changes are the opposite of what you'd see if they're in the front of the heart.
Moving on to ECG number 4, David. That looks like a quite abnormal ECG. What sort of things would you expect in the patient, and when would you see changes like this?
Often a patient like this one is surprisingly symptom-free. If you have something that maybe is a bit breathless with exertion, or perhaps it has a history of aortic stenosis, or somebody with a history of long-standing hypertension. This is an ECG of left ventricular hypertrophy. There are a number of different criteria that have been developed. One that I use is using V1 and V5. If you add together the S wave in V1 and the R wave in V5, if it's more than 35 millimetres, then that's suggestive of left ventricular hypertrophy. There are other criteria, but that one is reasonably reliable. Now, the other thing that goes with this is changes that look like ischemia. So in V4, V5 and V6, you can see there is ST segment depression and there is T-wave inversion in those leads, and that is consistent with ischemia. Some call it a strain pattern, but it's not really strain. It is true ischemia. It's ischemia due to hypertrophy, not an ischemia due to coronary artery disease necessarily. So it's one of the changes that goes with left ventricular hypertrophy.
So David, slide number 5 shows an ECG that is quite often difficult for country GPs to interpret, particularly if it's the very first ECG the patient's ever had on a standard insurance medical or such like. And we never know whether or not these kinds of changes are indicative of disease. So could you perhaps go through how we identify the changes and whether or not we need to attach any significance to them?
Absolutely. This is quite a common finding. In fact, an isolated finding of a left anterior hemiblock, which is what this ECG shows, doesn't necessarily indicate any disease that requires further investigation. If there is no history of any cardiac disease, left anterior hemiblock generally doesn't require any form of intervention. Usually it won't affect their insurance status, and generally what I would do is just note it, check to make sure there's no symptoms in the patient, and then really leave it at that. As far as interpreting it, I'll just quickly go through it. It's isolated left axis deviation, so you can see that leads 2, 3 and AVF have predominantly downward deflection, whereas lead 1 has a predominantly upward deflection, and that is the sort of thing that's how you would diagnose a left axis deviation, but there is nothing else abnormal about the ECG. It otherwise looks fine.
Slide number 6 shows again a fairly common finding, and the patients do often complain of an occasional thump in their chest. Is this something we should be concerned about?
Ventricular ectopics are incredibly common. Almost everybody has at least 1 or 2 ventricular ectopics. Some people feel them, some people don't. It's always worth doing an ECG if somebody complains of palpitations or a sensation of a thump in their chest. If you see 1 ventricular ectopic, it really doesn't mean anything. It's a normal variant. It doesn't mean anything. Ventricular trigeminy itself, again, apart from it meaning there's a lot of ectopics happening, doesn't really mean anything particularly. So you can have ventricular trigeminy, have no symptoms, and have a good prognosis.
Okay, so it's not going to trip into a run of VT necessarily?
Not necessarily. Most of the time it doesn't.
So could you have a look at slide number 7?
Most people, when they look at this, will immediately think of this as ventricular tachycardia, and indeed it is. Like I was saying before with the other abnormalities, you look at the patient. If the patient is compromised and they have a broad complex tachycardia like this, you cardiovert them, irrespective of whether you really think it's a VT or not. And final thing to say is if somebody's over the age of 60 and they've got a rhythm like this, it's always VT.
What about the patients who have little runs of VT and then revert to sinus rhythm?
If the runs are short, 4 beats, maybe 5 beats, that's actually relatively common, and it is associated with an increased risk if there's coronary artery disease associated with it. But surprisingly enough, some people have short runs of VT that we can't find any structural abnormality in their heart, and there's really no strong association with the increased risk. So yes, it's worth looking if somebody has a run of VT, but you don't necessarily always find something.
That, I think, is what we're seeing on slide number 8. And this would be when a GP would refer the patient on to a cardiology service to get an echo and a Holter monitor.
Yes, I'd recommend that in this particular patient you should look at it a little bit further. First of all, there's 2 runs of VT. You can see there's the first run on the left-hand side of the ECG, and a second one that's a bit longer, lasting 9 beats on the right-hand side of the ECG. And this does generally indicate some abnormality with the left ventricle, either a cardiomyopathy, a previous myocardial infarction, coronary artery disease, that sort of thing. So yeah, it is worth looking into a bit further.
Moving on to slide number 9, my suspicion is that this is a first-degree heart block. When does a GP worry about a patient whose ECG comes up looking like that?
Okay, so a first-degree AV block is defined as a PR interval greater than 0.2, which is one big square. If it's just over 0.2 seconds or 200 milliseconds, then it really doesn't mean anything in particular. If the PR interval is very long, so 0.3 like this or longer, then they often do progress to higher degree blocks such as second degree or complete heart block in the future. And again, take a careful history and see if there's any evidence of pre-syncope or syncope, or if there's ever been an episode where they've just collapsed without any obvious cause.
Okay, so this is something where the patient might require pacing, but only if they've got symptoms.
They won't require pacing just for the presence of a first degree, but if it goes into higher degree block, which is something that would be indicated by the presence of symptoms, then yes, it's possible.
A 10th ECG is something beloved of all cardiology students.
This is an ECG of Wolff-Parkinson-White syndrome. There are a number of different accessory pathways that can occur around the heart. Normally there is only a single channel that allows the electrical conduction to go from the atria through to the ventricles, and that's through the AV junction. If there's an accessory pathway, then if the transmission of electrical signal goes through there predominantly rather than through the normal channel, then you'll get what's called a delta wave. And if you look at the PR interval, probably the best place to look would be, say, lead 2, or you can see it in the anterior lead, such as lead V4. You can see that there's a P wave immediately followed by an upstroke, which is called a delta wave, and then the QRS complex. And that delta wave, or that upstroke, that early upstroke straight after the P wave, is caused by electrical activation through the accessory pathway and causes activation of the ventricle a little bit earlier than you would normally see. And so anybody who has Wolff-Parkinson-White syndrome should be seen by a cardiologist with a view to ablation of the accessory pathway.
And finally, David, the very last ECG in the pile. That looks like a very abnormal ECG to me, but I'm not too sure what's going on.
Sure. The reason I wanted to put this one in is because it's not that uncommon, particularly in emergency department setting, for someone, often elderly, to present with feeling unwell, feeling breathless, and presenting with palpitations. But the ECG, particularly on the automated reports, will often come out just saying sinus tachycardia. But if somebody is older and they have a resting heart rate above 100, it's usually not normal. It's usually due to an arrhythmia of some sort. So in this particular one, this is what's called a junctional or RP tachycardia. What you can see is the QRS complexes themselves are normal, they're narrow, there's no evidence of any obvious ST or T wave abnormalities, but if you look closely you can't see the P waves in the normal place. There's no P wave before each QRS complex. What you can see instead is that there's a QRS complex, and then straight after the QRS complex there are P waves, and that happens with every single QRS complex. So these are called retrograde P waves, and in this particular case what's happening is that the activation is happening at the site of the AV junction, and then the electrical signal is fanning out in both directions, forward as a QRS complex and backwards as a P waves. Yeah, and so an older person who presents with resting heart rate above 100, be concerned about the possibility of some form of atrial tachycardia or junctional tachycardia.
And a big thank you to Dr. David Playford, for being involved in the broadcast. Now, while Dr. Playford was doing his thing, the studio's undergone a bit of a transformation because suddenly we've been inundated with red wine and strong-smelling cheese. Johan, what's the go here?
Well, we had a discussion about what is good for you, right? And I think especially in rural Australia, we have to continue thinking about what is good for us. And there is a lot about wine, red wine, cheeses, beautiful chocolate, and you see all these things in the media. So I thought we better discuss what is really good for you. A glass of wine is good for many reasons. One, it gives you the opportunity to meet somebody because you don't drink alone. That's a disease if you drink alone. So you meet nice people and you talk about things. That's good for you. The second thing is that wine contains alcohol. Alcohol is an antioxidant. An antioxidant helps to pacify the rubbish built up in your arteries. So it is working against, it is a defense mechanism against the development of atherosclerotic disease.
Now, there's been an argument that red wine is better than white wine, but they both contain alcohol. Does that shoot down that argument, that red's better than white?
Correct. Now, there has been somebody in, I think, Chile with a lot of time. And they actually published a study last year where they measured the amount of antioxidants in several wines. Unfortunately, non-West Australian wines. So there is still something for somebody in UWA to do. Now, the argument between the white and the red wine was that the red wine grapes, or the grapes usually used for the red wine, have also in the skin also a different type of antioxidant. So it adds on to the effect of the alcohol of the wine in general. Now, that is not all the time true because, as you might know, there are different grapes varieties that can end up as a white or as a red wine. So my advice is just have a glass of wine in moderation and know that it's good for your health.
Define moderation.
Moderation is less than 4 standard drinks a day when you have an alcohol-free day. And this is a standard drink. I mean, I just drank from it. But the full glass is not a standard drink. Standard drink is, 150 mils or something like that?
Yeah. Being as how that's a burgundy glass, I'd say that's a half-bottle non-standard drink, that one.
Good. I like it though.
Johan, what about things like dark chocolate that are also recently being touted in the media as being good for us? Same deal with the antioxidants?
Same deal with the antioxidants, and I think that the media is a little bit biased because, as you know, it's also an Aphrodite. So I think that especially males should give the ladies dark chocolate. Can I just make one remark? I know that there are several people that are watching that have religious problems with drinking alcohol. You can have very similar benefits if you drink red grape juice.
Mm-hmm.
Without the alcohol.
Without the alcohol, because in the skin of the grape, you still will have a high concentration of antioxidants.
Not nearly as much fun, though.
It depends on what you believe in.
Fair enough.
All right?
Yeah, and quite a lot of our patients are now looking at their lifestyle and their lifestyle changes, and quite apart from drinking more red wine, they're also talking about things like taking selenium supplements or zinc supplements or fish oil or coenzyme Q. Could you comment on any of the herbal or supplemental things that actually have very good evidence or good evidence for cardiac benefit?
Not that many, unfortunately. There are a couple of things. One is that if you are exercising, independent of your weight, it's good for you. So even somebody of 150 kilos that does exercise 30 minutes a day will have a benefit from that, even when you don't have much weight loss. But they should go for maybe surgical measures. The second thing is that vitamin C has conclusively been shown in high quantities not to be beneficial for the prevention of heart disease. Vitamin E has been shown not to be beneficial for the prevention of coronary artery disease, right? And that is a little bit of a bummer, but because there was so much incidental reports that it was beneficial, people have considered to have large-scale trials, very well documented, very well controlled, and no significant difference has been found.
What about fish oil, though?
Now, fish oil, that is one of the exceptions. Fish oil has clearly shown, even in the 70s, when the Scandinavians started with it, that it does have a beneficial effect. Now, there are a couple of things about the fish oil. One is, and this is because now it's commercial, you have different qualities of fish oil tablets. You have to look at the concentration of fish oil. One tablet of fish oil doesn't do the trick. You have to have between 3,000 and 6,000 milligrams a day for sure. Then if you take a 90 cents can, if you still can get it for 90 cents nowadays, fat fish from Woolies, right? That will do the trick as well.
But it's got to be an oily fish, right? Like salmon?
It's an oily fish like salmon and sardines that you can use. And so people have to, I recommend usually that people look in the CSRO well-being diet book, 1 and 2. It's easy, it's very cheap. You can buy it at Big W. It gives you a good rundown what might be beneficial. What I don't like is that people go to the health shop, pay a lot of money for some supplement that they think might work but might not give them the job.
Olga mentioned selenium. What about that one?
Selenium is something that we definitely need. Q10 is another one. Is a substance that we definitely need. But in a normal person's diet, that is available. Now, there are some instances that I prescribe people selenium or Q10, and that is when they are on treatment for heart disease and do have specific complaints. Because we do know that some of our drugs, like the statins, like the Lipitors of this world, the Crestos of this world, the Pravacols of this world, sometimes deplete stuff like selenium and Q10 from our body. And if people have complaints that make me think that maybe they have that problem, then I give them the supplement. But there is not real evidence out there in the conventional Western medicine that to supplement that for everybody will give them a benefit. It will give the pharmacist a benefit, that's for sure.
Yeah. Johan, you were talking about patients on statins, and I know we're doing quite a lot of lifestyle assessments and lipid assessments on our patients. Quite a lot of patients will come in relatively low risk per their lifestyle factors, and you do their cholesterol profile or their lipid profile. Their total cholesterol is fairly high and their HDL is 2. Their risk ratio is really low because their HDL is so high, but the lab will still report that as a high risk result. So what's going on there, and what advice should we give the patient?
What goes on there is exactly the same as what David didn't mention, but what happens with our ECG machine. You do an ECG in a patient and the ECG will say abnormal. But if you give it to 10 cardiologists, they say it's normal. So it is the interpretation of the lab. It's like the LDL is being calculated from the other parameters. So you have to interpret, as you say, the results with the patient. There are a couple of things. One is that we can detect gene mutations in familial hypercholesterolemia. We know that if you have that, it puts you at a higher risk to get a problem related to your cholesterol. So if you have patients that have family members with high cholesterols that they know already, then my approach is different. Then I will send them to the Royal Perth Lipid Clinic and do a blood test for a gene test. If patients have low risk and they have a high cholesterol with a high HDL, we know that that contributes to the LDL calculation. So I tend to ignore the LDL. And I'll say, you'll be fine. And I'm not advising them to take a statin. If I have the same patient, let's say he's 42 years of age, his mum had a heart attack, he has a nice beer gut, and his lifestyle is not optimal, then let's say, I don't believe that he's going to be able to exercise, lose weight, and I do know that he has maybe a genetic makeup that makes him more prone to develop that problem. That is a patient that will give a drug. Which drug depends on, what the lipid profile is, but mostly you start with a statin and then you add in a fibrate or you add in ezetimibe or something like that.
Now I've got a few patients who are actually not at all tolerant of statins. What would be your first choice for a patient who can't tolerate a statin?
I would give that patient probably a fibrate, and there's only one fibrate on the market at the moment, so you give them fenofibrate, 145 milligrams. See how that goes. You put them on that for 3 months or 6 months and do the profile again whilst you try to encourage them to change their lifestyle. And if it's still high, you add isotrol. And if that doesn't work, then you have a problem.
Well, the patient has a problem.
Yes, because all the other drugs we have are intolerable stuff. I mean, you wouldn't eat it, I wouldn't eat it. I mean, you know, then you have to say, well, this is going to be your risk. That's it.
Yep. And Johan, you've spoken today about various tests and lipid clinics and such like that are available in Perth. What sorts of testing facilities are available in country areas?
Now, some of the cardiology groups in Perth, right, like us, do clinics in the country. And then it's more easy to get things done and organized because we go, you know, I go to Cal and Geraldton, go to the lab and discuss the possibilities. I would say that mostly, if you deal with one of the major laboratory facilities, you are able to get exactly the same tests done or organized as if the patient would be in Perth.
Yeah. But if they're needing an ablation or something, they would be coming to Perth?
There is no way that in the country you can get anything else apart from some centers will have nuclear cardiology, which is a very good alternative for an angiography to decide whether they need that. There are several centers that have the availability for cardiac ultrasound. I mean, cardiology groups will send out sonographers and they will have a weekly service. So that's okay. But for all the invasive stuff, people have to come to the city.
Yep. And speaking of invasive stuff, are valve lesions referred to cardiologists or cardiothoracic surgeons these days?
Valve lesions are always referred to a cardiologist because that's a doctor. I used to call my surgeons butchers.
Plumbers?
Well, no, we are plumbers. We are plumbers. They do the cutting and, you know, hacking and stuff like that. Now, the cardiothoracic surgeons usually operate valvular lesions on indication of a cardiologist. Now, you can read in magazines that cardiologists try to advance the field of percutaneous intervention. So we try to go up the groin and try and fix valves as well. And there are some experimental programs going on in the world, and we're trying to set up a program in Royal Perth as well for aortic valve replacements through the groin. But that is in its infancy at the moment. So the evaluation happens by a cardiology team, and then together with surgeons often, and if the patient is a suitable candidate, he'll be offered the surgery.
Johan, just before the program, we were also talking about various drugs that could influence funny rhythms, and you'd mentioned that ADHD drugs can sometimes be seen given along with tachyarrhythmias. Would you like just in a few seconds that we have remaining to comment on that?
Yeah, it's not because I'm Dutch and it seems to be a drug haven, but the use of amphetamines without a real clinical reason, I think, should be discouraged. Because if you use amphetamines, speed, to treat people's personal behavior, I think we could all take the stuff. I'm not so sure that it really benefits those patients. And the patient I mentioned was referred to the GP to me because she was very agitated and had heart rates over 100 to 120 all day because she was taking Dex all the time. Why? Because she had an adult ADHD syndrome, and the last time she saw the psychiatrist for that was maybe 10 years ago. So I would like to offer a word of caution. We do know that these drugs, like amphetamines, like cocaine, like speed in the bottle, like crack, like the party drugs, do cause myocardial infarction, do cause congestive cardiomyopathy, and those people suffering from that are really stuffed because sometimes those results are irreversible.
Okay, so we'll certainly keep an eye out for those. We might have a look now at some more technological advances in cardiology. Jerry.
Thanks, Olga. Yes, there have been some advances recently in our ability to create images of the heart and major vessels non-invasively. Some of the techniques developed have received enough publicity that people may well be coming to you for information about them. With this in mind, we went out to speak with Dr. Jenny Deeg and Dr. Laurie Dembo to find out more about the imaging techniques and what they can tell us.
Hearts West is a practice which specialises particularly in echocardiography, so cardiac ultrasound is our thing. Our mainstay is transthoracic echoes, and so that is obviously useful in all areas of cardiology, whether it be cardiomyopathy or murmurs or endocarditis or ischemic heart disease, heart attacks, all of that. And we're particularly proud of the fact that we do three-dimensional echocardiography, which is an amazing new technology, and real-time three-dimensional images are just magnificent and really aid us in our valvular heart disease in particular. Transthoracic echo, I think, is a mainstay of cardiology. I think it's like the ECG. It's simply amazing. You know, it's a non-invasive tool. It's not dangerous to the patient. You get to look at all the heart walls and see if there are any regional wall motion abnormalities to suggest you've got ischemic heart disease. You get to look at the overall heart function. Does the patient have a cardiomyopathy, or have they got a normal structural heart? You also get to look at all the valves, all 4 of the valves. You get to see if there's rheumatic heart disease, you get to see if there's mitral regurgitation, aortic stenosis, tricuspid regurgitation. You also get to see the weird and wonderful, so the congenital heart disease, the hypertrophic cardiomyopathies, the apical hypertrophies, all those things. If you've got a patient with hypertension, have they got a left ventricular hypertrophy with that's going to cause a problem? Do they have coarctation of the aorta and therefore secondary hypertension? Actually, transthoracic echo goes with every aspect of cardiology, and I can't think that there's a single patient I see in my rooms as a cardiologist who doesn't get a transthoracic echocardiogram to exclude structural heart disease. It's ubiquitous. You also get to look for atrial septal defects, patent foramen ovalis, both of which can now be closed by percutaneous intervention if that's necessary. Echo machines over the last few years have become very portable. There's actually a very interesting article on rheumatic heart disease by Professor Sellermeyer from the Royal Prince Alfred, and basically saying that portable ultrasound should be used throughout northwestern Australia and Africa in order to diagnose rheumatic heart disease, particularly in children, and actually save the country vast quantities of money and save lots of children's lives. With modern portable ultrasound machines, the patient shouldn't have to come down to the city to have a cardiac ultrasound. They should be able to have it done in the country, and those images can always be digitally transferred down to the city. 3D is very exciting. I believe this is the future of echocardiography. The particular patients that I want to have three-dimensional echo would be my patients who are going to have valve surgery, so if they need mitral valve surgery or aortic valve surgery. It's particularly good for our atrial septal defects or patent foramen ovalis that are going to be closed, because the interventionalist can see the defect in 3 dimensions. They can actually see the mitral valve and say, that's the scallop that needs repair, or they can see the aortic valve and see the perforation and where they're going to have to put a stitch or where they're going to replace it. And so it's just taking it all to another level. That's where it makes all the difference. In fact, 3-dimensional transesophageal echo is now available, and that's done during those percutaneous procedures. The whole thing is done under the control of 3-dimensional echo to see where the wire's going and whether or not the Amplatzer device is appropriately aligned or loose, or where exactly it is. 3-dimensional echo also gives us a better ejection fraction, a more accurate ejection fraction, because you're not just looking at a few walls, you're looking at all the walls together. The 3-dimensional transducer is a slightly bigger footprint, which means it's a slightly bigger probe, but the technology is simply amazing, and what you get is real-time 3D. So as you've got the probe on the patient, you can see the heart in 3 dimensions, which is, I believe, a huge breakthrough in the technology. I think the main ones who critically need an ultrasound of the heart are the people with valvular disease. So when you hear a very loud murmur of mitral regurgitation or possibly aortic stenosis, I think it's very important that those people come down to the country and we assure that they don't have severe aortic stenosis or they don't have severe mitral regurgitation, because that would require urgent treatment. Similarly, if you suspect someone has a cardiomyopathy, if they've got a large heart on their chest x-ray and they're very short of breath, I do think that finding out exactly what their ejection fraction is and how weak their heart is a very important thing. And when you do that study, you can also work out Is it a regional wall motion abnormality? So is this likely to be ischemic heart disease that may need coronary angiography to sort out and stent or coronary artery bypass graft surgery? Or is this a primary cardiomyopathy? So I think those are two cases off the top of my head where I think it is worth sending the person down to the city to get an ultrasound to sort that out.
What we want to understand with a CT is, does the person who's sitting in front of you have disease of their coronary arteries? Because as a doctor, your biggest challenge is to try and get around the people with chest pain that are really from the heart, the ones that are going to drop dead, and the ones that don't have chest pain from their heart, because as you know, there's a big kind of mix of those people. So what a coronary CT is it's really two separate tests put into one. And what we do is you have a drip put into your cubital fossa, and through that drip, what we do is we put some contrast in. You take a breath in, you hold your breath, and about 10 seconds later, we have a picture of your coronary arteries. In some people, even the function of the heart, and we can also have a little look at valves, although it's currently the test of choice for that is echo. And what we do with that coronary CT, and also with the calcium score, which is a bit like a test looking at the amount of scar in your arteries, what we do is we examine that for coronary atherosclerosis. The reason that the CT is such a fantastic way to define atherosclerosis is because of the way the disease works. See, the disease doesn't work the way that most doctors imagine it in their heads, which is a narrowing over time of the coronary arteries. The disease works by starting in the wall of the artery, and it's not a localized one single lesion. It's a diffuse inflammatory disease. It's like having pimples, and the disease starts in the wall of the artery and it grows outwards for a long time before it grows inwards. And what's happening the whole time with that atherosclerotic lipid inside the coronary artery wall is that the wall pops and heals and pops and heals, and you get these little bits of clot that form in the artery and break up, and it's a very active process. One of those clots can block the artery completely and you can have a heart attack. But usually it's been 15, 20 years even sometimes from the time that you start having this disease to this time that you might have your first symptom. And the problem is that the way that we've been looking for disease until now is by starting with the end in mind. And what we've been saying is, well, let's wait and find a narrowing in the artery, and then let's put stress on the heart in the area of that narrowing. And then that will cause a change in the ECG or a change in the echo or a change in the nuclear properties, and we'll be able to see that. But it all relies on the premise that you've got a narrowing in your coronary arteries to begin with. And that's not how we know that coronary artery disease works today. What we know is that most of the time you could have a coronary angiogram, one of those invasive ones, through your leg that you come to hospital, and we could do the angiogram an hour before you had a heart attack. And almost always, more than 75% of the time at least, you will not see a narrowing. So we have got to move away from the idea that the disease is a disease of narrowing. So if you understand that the disease has got three kind of major characteristics, it's diffuse, it's eccentric, that means it starts in the wall and it grows outwards before it goes inwards, and it's chaotic. That means you can't predict where the popping plaque is going to cause a problem. If you understand those three things, you understand why it is that what you need to do is image the whole coronary tree to define the patient's overall risk, not just one lesion. If you've got someone sitting in front of you and they've got chest pain and you're not sure if it's from their heart, what do you need to do? Well, when the patient has a coronary CT, what you'll be able to define is, does the person have atherosclerosis or do they not? If they do not have atherosclerosis, this test is 100% accurate. You don't need to treat them. No atherosclerosis, no treatment. For all the others with atherosclerosis, they fall into different groups. The small percentage of people that have severe disease, these people can need a coronary angiogram. The majority of people who have mild disease, no tight luminal stenoses, but coronary artery disease, as if you have pimples, those people need systemic therapy, and that's aspirin, a statin, exercise, and meticulous control of their risk factors. This is a very motivating test for people. When they see their coronary arteries, people respond differently. And then there's the small group in the middle, the group of people that have a luminal stenosis. It's about 50-60%, and those people should have a stress test, because now when you're having a stress test, you've got a 60% or so lesion. That test becomes much more sensitive and specific because you know they've got a lesion already. Now you're just trying to define how sensitive, how functionally significant that lesion is. So why is coronary CT sweeping the world and changing the way that people respond to chest pain. It's doing it because it gives doctors what they need. It gives you an answer to the question, do I need to treat my person or not? Do I need to treat them and send them to a cardiologist or not? And that's what people want when they come to a doctor. Help me, do a test if you need to, and if you do the test, make sure it's something that will change my management.
Our thanks to Doctors Jenny Deeg and Laurie Dembo for their time and expertise. Now, Johan, how available are these techniques for rural GPs? Do you send any of your patients for this kind of imaging?
I do send some of my patients for this imaging, but it's a highly selected group that need this type of imaging. And as Laurie explained, for instance, for the CT coronary angiography, it's not about the stenosis that you're worried about. It's about what the function is of the cardiovascular system. And if you want to assess that in the rural area, I think you're better off by first doing a standard stress test, or if it's available, a nuclear stress test. Wow. I think that's a very high yield investigation for which the patient is not much out of pocket and gives us very good information.
Now, earlier we were talking about the therapeutic effects of alcohol as it is contained in wine. Our camera crew are very keen to know about the therapeutic effects of alcohol as it is contained in beer.
I knew you were coming back to that. God, you were not going to talk about this other relationship issue too, rubric alcohol and stuff. Now, unfortunately, I have to report that recent studies show that the beneficial effects of beer are nullified by the amount of carbohydrates there. So beer as an antioxidant method is not a very good suggestion. So if you have to advise patients what type of alcohol they should consume, you have to stick to all kinds of wines, fortifieds, or spirits. Spirits without Coca-Cola and without bubblies.
So beer with a whiskey chaser then?
The chaser is all right. But I think it's important that you have to enjoy your life. So if you want to have a beer, enjoy your beer. Have a nice beer though, but don't go overboard. If you get the beer gut, that's too much.
I think the crew has just breathed a sigh of relief on that last point, Olga. Any final points from you?
Nothing from me, but perhaps Johan's got something that he'd like to leave with the country doctors?
Well, I think that, first of all, for country doctors, especially if there are many that are not Australian or Australian trained, I know from experience, I was a non-Australian country doctor for a while as well, that it might be very difficult to find your feet and see where you go and what to do with all the advice you get. My advice is, just don't sit there, don't sit on it, but give us a call. You can always call us. We got fantastic facilities in the country. We got fantastic facilities in the city. We got now a beautiful new CCU, the best in town, I would say. Great for bariatric surgery, great for people with cardiac disease. And I think that for the people in the country, it is very important to keep the liaison with doctors that come and visit in the country and to make sure that they can give the patient the options. I think the options is the idea. Many patients would like to be told that we can do this for you, you can see this person that comes up here. If need be, you might need to go to Perth, you might not need to go to Perth. And sometimes a regional centre like, Geraldton or Kalgoorlie, a larger centre, you can refer to them.
And who knows now, with royalties for regions, perhaps there might be more facilities out there in country hospitals.
Well, we can hope so.
Thank you very much, Johan, for being with us tonight.
Thanks for having me. See you next year.
That's all the time we have for tonight. Now, don't forget, if you'd like to review this program or any previous program, you can watch them online or download them as a video or audio podcast via the Rural Health West website. That's www.ruralhealthwest.com.au. We're back again on the 3rd of March with a program on obstetrics. Now, we'll be filming a lot of the March broadcast in Kalgoorlie over the next couple of weeks. So if you do have any questions you'd like answered, then please get those evaluation forms into us as soon as you possibly can. Thanks again to our guest tonight, Dr. Johan Janssen, and to Dr. Olga Ward. And thanks to you for taking the time to join us. Good night.